Hi everybody, welcome back. This is the third video in the series of Hobson's Choice Modern Medicine versus Integrated Medicine. We are on a journey to make the patients more aware or the patients more empowered to choose between modern medicine and alternative medicine, and also to give an idea about doctors in general about what is going around. Now, this is the third series video. In the first video, we had discussed what is CAM or complementary and alternative medicine. We were surprised by the WHO stand and strategy. They have a robust strategy extending from 2014 to 2023, where they are going to propagate integrated medicine. And this is definitely going to haunt us, haunt the practice of uh, conventional medicine or modern medicine in the years to come all over the world, because the stand taken by WHO is bound to influence heads of state and governments, and any opposition to it will be difficult for even the practicing doctors. Now, we also looked at the practice of doctor practice in developed countries, and we found that the popularity of CAM is increasing even in very developed countries like America, Germany, etc. And in the last video, the second series of the video, we looked at the safety of CAM and the regulatory aspect of CAM and integrated medicine. We found out that the regulation was very flimsy and there are a lot of questions of safety of CAM. Now, those who have not seen these two videos, you can find the link of video 1 and 2. I have given you the link here. And I am Dr. A. Padmanabhan, pediatrician, and let's take this journey forward. In this video, we will be essentially looking at what is evidence-based medicine. This will look very elementary for the practitioners of health personnel, but this is aimed more at the general public. Why do conventional medicine doctors consider EBM as a basic tenet of present day practice will be the other matter, the second matter we look into it. We will be discussing. This is the basic difference between modern medicine doctors and the traditional medicine practitioners or alternate medicine practitioners. The alternate medicine practitioners base their practice on anecdotal evidence and something which is written and practiced for 2000 years, 3000 years, they take it as evidence, which the conventional medicine doctors do not agree with. Therefore, this is the crux of the difference of opinion between modern medicine and alternate medicine, and we will be discussing it in some detail in the present video. To be honest, evidence-based medicine was not there at the beginning of medicine. If you look at the history, some of the path-breaking discoveries were done without any clinical trial or any evidence. I hope you know this person, and all medical personnel should know this. Know him. On May 2014, 1796, Jenner took fluid from a cowpox blister and scratched it into the skin of James Phillips, an 8-year-old boy. Must have been a very unethical thing to do. A single blister rose up on the spot, but James soon recovered. On July 1, Jenner inoculated the boy again, this time with smallpox matter, and no disease developed. He would have been arrested under POSCO in today's conditions. The vaccine was a success. Doctors all over Europe soon adopted Jenner's innovative technique, leading to a drastic decline in new sufferers of the devastating disease. That was the birth of vaccination and immunization. Where was the evidence-based medicine? Where was clinical trial? None. You must know this man who also changed history and the way you and I live. Alexander Fleming, first who discovered penicillin. First clinical success was in ophthalmia neonatorum. He put a few drops of penicillin on the eyes of newborn babies in ophthalmia neonatorum and prevented blindness. But the most important clinical test was in August 1942, when Fleming cured a single case of streptococcal meningitis. Harry Lambert was the patient, and that was enough to put it as a clinical trial in Lancet in 1942. And the British War Cabinet set up a committee to produce penicillin in a mass scale. And the rest is history. Where was evidence-based medicine? Where was clinical trials? None. The history changed without any one of them. Then why are we so much bothered about it? Well, here is another man who changed the way you and I live and changed history and medicine. It was Robert Koch, a Nobel laureate in 1905. He lived in 1843 to 1910 and often called the founder of medical bacteriology. He is credited with discovering the tuberculous bacilli, which is Mycobacterium tuberculosis, demonstrating the first time in history the life cycle of anthrax bacillus under controlled vitro conditions, and identifying Vibrio cholera as a cause of cholera. He came to India and discovered the Vibrio cholera bacillus. Now, for this, he was awarded 1905 the Nobel Prize, but he was not that lucky. He claimed that tuberculin would cure tuberculosis, and that was a tragedy because many of his patients started dying. And there was even at the last stage, he was haunted by this. Stones were thrown at his house. There was a scientist claim wanted this Nobel Prize to be withdrawn. What a tragedy to a man who changed history and changed medicine. This wouldn't have happened if there was clinical trials and evidence-based medicine. Even the brilliance of probably the most brilliant scientists of the world, you have to check it with evidence. Well, if you are a human being, these photographs should upset you. Here is a boy without a hand, finding with great difficulty his writing. What about this boy? Doesn't have both the upper and lower limbs. What do you feel if I tell you there were hundreds and hundreds of these babies born across the world, especially in Europe and to some extent in America? You would have guessed what, and what did you say if these were a man-made disaster because of a medication? Yes, you would have guessed what I'm talking about. Thalidomide, which formed, this is phocomelia. The limbs were not properly bound. Now what happened is, for those who don't know much about it, in the post-war era when sleeplessness was prevalent, thalidomide was marketed to a world hooked on tranquilizers and sleeping pills. Now at that time, 1 out of 7 Americans took them regularly. Around the time, Australian obstetrician Dr. William McBride discovered that the drug also alleviated morning sickness. He started recommending this off-label use of the drug to his pregnant patients, setting a worldwide trend. And by 1960, thalidomide was marketed in 46 countries, with sales which nearly matched that of aspirin. In July 1962, President John F. Kennedy and the American press began praising their heroine, FDA Inspector Francis Kelsey, who prevented this drug approval within the United States despite pressure from the pharmaceutical company and FDA supervisors. Therefore, America escaped better than Europe because one particular lady, this lady, had prevented this being FDA, getting the FDA approval there. I hope she was the WHO director now. She would have probably prevented the COVID epidemic. Now, Kelsey felt the application of thalidomide contained incomplete and insufficient data on its safety and effectiveness. Among her concerns was the lack of data indicating whether the drug could cross the placenta, which provides nourishment to a developing fetus. When there was no data, she said, no, I will not approve it. And that prevented thousands and hundreds of American women from having abnormal children. But you know, and even at that time, clinical trials did not require FDA approval in America. So much so about 20,000 Americans had already undergone the clinical trial of thalidomide. And maybe some of them got from Europe also this medicine because this was a very good tranquilizer. The tragedy surrounding thalidomide and Kelsey's wise refusal to approve the drug helped motivate profound changes in the FDA. Therefore, this was a path-breaking movement actually that happened because of thalidomide. And therefore, they passed this Drug Amendment Act in 1962. They tightened restrictions surrounding the surveillance and approval process for drugs to be sold in US, requiring that manufacturers prove that they are safe and effective. They have to prove they are safe and effective before they are marketed. Each drug has to be proved. And when FDA adopted it, slowly other countries followed suit. Now the drug approval can take 8 to 12 years, involving animal testing and tightly regulated human clinical studies. Therefore, that's how everything changed. The clinical trial came into existence. And you can understand is fully justified. No person can dispute this. I don't think any human being can dispute the reason behind the clinical trials, the need for clinical trials. Now, all the medications nowadays has to go through 4 phases of clinical trial. In phase 1 trial, this basically we are looking at is the treatment safe. It involves animal studies. Very few patients are given, determine safe dosage, identify side effects. Only about 70% of the drugs in phase 1 go into phase 2. That means 30% is discarded. In phase 2, you are looking at does the treatment work? Here, safety, does it work? Test effectiveness, further evaluate safety. Now, once you pass phase 2, only 33% of the drugs, 1/3 of the drugs goes to phase 3. Now, it is not enough that it is safe and effective. It should be better than the drugs already available in the market. They should have some advantage. What's the point in reinventing the wheel? Therefore, is the treatment better than what's already available? That's what you look in phase 3. Confirm effectiveness, monitor side effect, compared to other treatment. This is a different thing. Collect information. More number of patients. As the phases go, the volunteers are more and more on whom it is tested. Here only about, from the beginning, only about 1/4 of the drugs go into the next phase, which is phase 4. And here we would like to know anything, we would like to test it after some years when it is already given approval. Anything that we never anticipated, that is provide additional information after approval, including risk, benefits, and better use. You may have never anticipated something which may crop up once you use it on a large scale in the community. This is phase 4. Now these phases are also done in vaccine also, and each vaccine also takes us years and years to get approved. But regarding COVID vaccine, because on an emergency basis, they waived the phase 4. Therefore, it can come about in a few months' time. And as far as Covaxin is concerned, even phase 3 was not completed satisfactorily, even now. Therefore, if you look at the history, the thalidomide tragedy, etc., nobody can dispute why people are so careful, why modern medicine is so careful to, before they approve a drug. Do no harm is one of the basic principles, tenets of medicine therapy. Even if you are not able to do much good, do no harm. That forms the basis of medical practice. Now, one of the reasons why you require clinical trials and not anecdotal evidences, anecdotal, that means a single observation or a period of observation by a few doctors who themselves may be very senior, or what is written in the book, is because of the placebo effect. Now, what is placebo effect is, it is well known that even a nice talk by a doctor before taking a placebo will increase its effect. Placebo means it's an inert substance. It may contain no active material. You giving it, you say you give a vitamin for a patient, it contains nothing like gelatin or something, and you give it, say, telling to a patient that this is left, it will cure your headache. 50% of the people will believe better, will feel relief. This is called the placebo effect. Now, suppose you have a patient whom you have done massage, you have been talking to him nicely, you have given him rest, special food. After 1 month, definitely when you feel better, it is difficult to understand whether the medicine, the massage, or the placebo had this effect. Therefore, you have to do clinical trials to negate the placebo effect also. Now, another thing which we have to avoid is bias. Bias is any systematic error in the epidemiological study that results in incorrect estimate of the association between exposure and outcome. The word systematic error is important. Bias doesn't mean that you are malingering or you are doing something wrong. You are manipulating. It's different. Now there are very different types of bias. I would just try to explain to you by just selecting one, what is called the selection bias. Now, what do you mean by that systematic error will become evident to you when I give you the example. Now, suppose you have a doctor who works in a factory. He's a general practitioner in a factory. He's working very healthy. He's seeing very healthy workers. He might come and tell you, no, COVID is just like any other flu. Many of my patients have got it and they have all recovered. On the other hand, you come to see an intensivist who's working in an ICU. He would come and tell you that his observation would be that COVID will be a very severe disease, which about 50% mortality. Now, therefore, this is what is called as a selection bias. It's a systematic error, but they are not manipulating the facts. Therefore, whenever there are individual observations, this bias sets in, and clinical trials overcome that. Other than bias and placebo effect, something else which can distort your judgment is confounding. Confounding is a situation in which the effect or association between an exposure and outcome is distorted by the presence of another variable. This may look very complicated, but it will be very easily explained in the next slide. Another reason why simple observation can sometimes lead on to mistake is you can have an observation like exposure to alcohol will increase lung cancer. Some doctor may find that most of his lung cancer patients are heavy alcoholics. But what you mean by confounding is the third thing, which is related to both of them, may be the underlying reason, smoking. We all know that smoking causes lung cancer, and many people who are alcoholic are also heavy smokers. Therefore, when the doctor thought that the alcohol use leads on to a lung cancer because many of his lung cancer patients were using alcohol, it is actually a third thing, that is smoking, which is responsible for that. If he makes a public effort to decrease alcohol, it is not going to decrease lung cancer, only smoking will. Therefore, isolated observations can lead on to mistake because of placebo effect, because of bias, and because of confounders. And these can be overcome to a certain extent by clinical. Just to give you an idea of how scientific studies are done, a group of patients are selected at random to get placebo or the real drug. This is selected at random by the computers by allotting numbers. Neither the doctor, the treatment team, or the analytic team at the beginning knows who is getting the placebo and who's getting the real drug. The placebo looks like and tastes exactly like the real medicine. They are only numbered. And then the effect is analyzed. Now the placebo also has an effect. The real drug, if it is effective, will have a better effect than the placebo. And the difference is the real effect. Now when you do this difference is analyzed by the statistician to make sure that it is statistically significant. So that to make sure that the difference is not observed by chance. It is not possible for me to explain all the facts about real scientific studies, but this gives you a glimpse of how it is done. And is only after this studies which are done has nothing to do with modern medicine alone. This is how anything is put to scientific scrutiny, and only after it stands this test of scientific scrutiny, a treatment is accepted in modern medicine. Any intervention is accepted and advised to the public. To take a story forward, in 1972, this gentleman, Professor Archibald Cochrane, produced a book called Effectiveness and Efficiency, Random Reflections of Health Services in 1972. As they often said, it changed the practice of medicine in a different way. Now, what is his vision of evidence-based medicine? This book strongly criticized the lack of reliable evidence behind many of the commonly accepted healthcare interventions at the time. He took on the most of the great consultants of the time, and they said that their practice, there was no reliable evidence to show that it works. His criticism spurred rigorous evaluation of healthcare interventions and highlighted the need for evidence in medicine. His call for collection of systematic reviews led to the creation of the Cochrane Collaboration Archive, which helped lay down much of the foundations of evidence-based medicine. From there, the word evidence from clinical trials became evidence-based medicine. What he essentially showed was the various studies have found significant variations of care among practitioners. There was no uniformity. This because many practitioners follow a logical treatment plan based on their understanding of the pathophysiological process. However, what may seem like obvious logic is often flawed and cause unnecessary patient morbidities. What do you think is logical treatment doesn't work on the real ground. This is what he showed. And he changed the practice from logical medicines to evidence-based medicine. I will illustrate this from what we learned in how we applied it to COVID treatment also in the next few slides. Now we will explain this further. Now, in the beginning, all of us would have been aware that hydroxychloroquine as post-exposure prophylaxis was put forward. The logic behind it was hydroxychloroquine have in vitro mean in the laboratory activity against SARS-CoV-2 virus, which is the one which causes COVID-19. Therefore, there was logic and therefore there was nothing wrong in putting forward. And we also know that India started exporting and producing this drug in a mass scale and exporting it to many countries. And there was a clamor among the world countries to get hold of this medicine. Now came the New England Journal of Medicine. Immediately they applied it. Nowadays things are moving very fast. Randomized trial of hydroxychloroquine as post-exposure prophylaxis for COVID-19. After high risk or moderate risk exposure to COVID-19, hydroxychloroquine did not prevent illness compatible with COVID-19 or confirmed infection when used as post-exposure prophylaxis within 4 days after exposure. Therefore, that was the conclusion. Therefore, the conclusion was that WHO also arrived at the conclusion very fast that it was not effective. Another treatment put forward was the plasma. You know that there were a lot of it, even in the visual media, there was a lot of requests for people who are recovered from COVID to supply their blood. And a lot of volunteers went to the blood bank donating plasma so that it might help the next patient. The reason was that convalescent plasma has been used in the treatment of infectious diseases under the assumption that passive immunization can jumpstart the immune system because a patient's plasma after recovery will contain antibodies. And therefore, they thought it was logical to think that it would protect against decrease the severity of the subsequent viral diseases. Now, this has been tried in certain other pediatric infectious disease also. But what was the double-blind study showed? A randomized trial of convalescent sera in COVID-19 severe pneumonia, no significant difference was observed in clinical status or overall mortality. Therefore, what happened? Not effective. Again, suddenly this treatment was abandoned. Now comes the next thing. Remdesivir is an antiviral agent for the treatment of COVID. What was the rationale? Remdesivir is an inhibitor of viral RNA dependent with an in vitro inhibitory activity against SARS-CoV-1, which causes the COVID-19 virus, COVID-1 virus, which causes the COVID-19 disease. Now, what was the result of it? Again, in New England Journal, remdesivir treatment final report. Remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 and had evidence in severe respiratory infection. Therefore, you found out that among the three which we embarked upon, only one was found to be evidence-based or had evidence on the level of the patient. Other were logical, but they did not have. If we had not practiced evidence-based medicine, we would have been wasting our effort and energy and money on these two things also. Subsequently, steroids has also been shown to be effective to a certain extent. Therefore, this is how evidence-based medicine works at the ground level. Evidence-based medicine is the basis of it is evidence, and there is a hierarchy of evidence in question. Individual opinion as the lowest in this hierarchy. Up comes case report, case series, case control trial, cohort studies, randomized controlled trials. Now, randomized controlled trials are the highest in evidence, and systematic review of randomized controlled trials with or without meta-analysis is the highest evidence in evidence-based medicine. As the pyramid goes higher, bias becomes less and less. Therefore, in many questions, many clinical questions, you may not have systemic analysis, you may not have randomized controlled trial. You try to get the best evidence to come to the evidence to your final decision. Now, this hierarchy of evidence helps in processing to contribute to evidence-based medicine. From the primary series of studies, we get primary studies, then it goes to systemic reviews, and the decisions. These lead on to guidelines. Nowadays, in most of the conditions in clinical medicine, there are guidelines, internationally accepted guidelines as well as national guidelines. And these summaries and guidelines are what guide the doctors. Therefore, it gives you some amount of uniformity and in allowing doctors to practice evidence-based medicine also. Helps in practicing evidence-based medicine also. This summarizes the the real matter of the evidence-based medicine or EBM. The best available research evidence is used to practice EBM. But what is often forgotten is clinical expertise is not given a goodbye, because many times evidence may not be there, and then in that particular portions clinical expertise also is used to make the guidelines for evidence-based medicine practice. And something which is often forgotten is nowadays more and more patient groups are also involved in the making of evidence-based guidelines. If you look at especially the American guidelines, if you look at the people who are participating, you will be surprised to find asthma patients also participating in our making of the asthma guidelines, because what the patient values and what is his preference are also taken into consideration. Therefore, it is not pure science. Medicine is not practiced as pure science in evidence-based medicine. Clinical expertise and, more importantly, patient values and preferences are also taken into consideration. In 2007, a poll conducted by the British medical journal Evidence-Based Medicine was included in the 15 most important advances in medicine since 1840. Since 1840, one of the greatest advances in medicine is the evidence-based medicine, one of the 15 most important advances in modern medicine. You can understand from 1840 onwards, including discovery of penicillin, etc. Therefore, there's no question. Outcomes of well-designed clinical trials with their statistically significant difference between treatment modalities are sacrosanct for medical practice, not unreliable personal anecdotes. How come this modern medicine, which is conventional medicine, will now be integrated to medicine which has to other systems of medicine which may not be based on evidence basis? That is the basic difference of opinion. Whatever the WHO says, whatever the acceptance in the patient population might be, the doctors in modern medicine are not ready to reconcile with this factor. With this, we come to the end of the video 3 of the evidence-based medicine. Modern medicine versus integrative medicine, the Hobson's choice. What we essentially looked at, why does conventional medicine consider EBM as a basic tenet of present day practice? I hope it has become very evident to you why it is so. Now in the video number 4, which comes soon, I will be looking at what is the opinion of alternative medicine practitioners on EBM and what evidence is there for the practice of alternate medicine. That's what we'll be looking at video number 4. And video number 5, I summarize everything and what is the best choice in front of the public and what the future holds for the medical profession in the years to come. Thank you for listening to me. My for other educational videos are on this link, and I also my blogs are on this link. Thank you very much. Till we, I mean, goodbye till we meet next time.